upcoming sessions. Just a reminder that there are parallel sessions. So if you're going to a different session, you have to select a different Zoom room. So it's the independent rooms, one for each session. You can find all this information on our virtual workspace in Outspace. And I could put the chat in the link, the URL to access the Outspace, where you have the details of all the program we are following. We are also now live on social media, so it's good to have everybody with us today and following us in the different channels. It's been a long day. We are going to have today a total of 9 hours and 30 minutes of sessions. Tomorrow, more or less the same. So a total event on 18 hours of content. Premium content, I would say, in health data quality. Please take your seats as we are going to start momentarily. I'm also sharing in the chat here access to the platform where we have the detailed program that we are following throughout these 2 days. Questions are welcome here in Zoom chat, Maria, or should we stick to the presentations? Are you accepting questions?
I think so, yeah, it's fine.
Okay.
You should forward them to us.
Okay.
Yeah.
I will do that as soon as we have here Zoom participants. So please be so kind to join us. And we will start momentarily. So for the moderation of this session, we have here already in the table Maria Marques. She's a senior researcher at UNINOVA. UNINOVA was just previously presented by Ricardo Jardim Gonçalves, and she's a PhD in Electrical and Computers Control and Decision, MSc in Electrical and Computers Control Systems, and of course also in the degree in Engineering, Electrical and Computers. Okay, so guest speakers, please welcome, join us here in the table, and maybe you can already start the session. It's 1 minute past, so join us. Have a seat.
Paul, can we start?
Maria, yes, you can start. The floor is all yours, Maria, and wishing you a good session.
So good afternoon, everybody. I hope that you can hear me well. And thank you, Paul, for the nice introduction. So as Paul mentioned, my name is Maria Marques, and I'm a researcher at UNINOVA. I think that today you have already heard a bit about us, and I invite you, of course, to get to know a bit more outside in our booth. We are there, and my colleagues are there to let you know more details about our work. For today's sessions on new frontiers in data quality, we will have 4 speakers. 3 of them will be present in the room. 1 of them will be attending remotely. The first one is Rachael Powell from Wales. We will then follow to DriesHens from Lynxcare. Then Sergio Roll from the Brazilian Society of Minimal Invasive and Robotic Surgery. And then we will end up with Ravi Shankar from the World Health Organization Geographic Information Systems. So I invite you, Rachael, to start your presentation. The plan is to add that each speaker will have approximately between 10 and 15 minutes. And then we will, of course, have some time for discussions also from the remote audience. So thank you, Rachael.
Can I just check colleagues can hear me at the back? I think the mic's on. Afternoon, everyone. I'm Rachael Powell. I'm Associate Director of Information Intelligence and Research at Digital Health and Care Wales, and I've been asked to give you my views and my thoughts and perhaps the Welsh perspective on new frontiers and data quality. I wanted to start my presentation with a little bit of information on Wales itself and to contextualise some of the challenges and opportunities that we have within Wales. Wales is a country in the southwest of Britain. It's renowned for its rugged coastline, its mountains, its language, and of course, its love of sport. We're a population of 3.1 million people, and we have treble the amount of sheep. We're a bilingual country, and approximately 25% of the Welsh residents actually speak Welsh. And if you ever have the opportunity to visit Wales, you'll notice on all the signage and all of our publications and such that Welsh language is normally the first translation followed by English. So again, there's some wonderful opportunities and challenges in that respect. We also have 3 national parks covering approximately 20% of the land mass of Wales, and most renowned is Snowdonia National Park and Brecon Beacons. We've also got more castles per square mile than any other country in the world. So it really is a really nice place to visit, and I think if you get the opportunity, would very much welcome you. And by the way, I'm not sponsored by Visit Wales, and I know that the event today is by Visit Porto, but perhaps I should have been. The actual facts with regards to the health of our nation are a little bit more sobering, unfortunately, and I spoke about the castles covering more square mile than any other country in the world, but unfortunately poor housing quality it's a wider social determinant of health that does have a significant impact on the health of our population, both in terms of mental health and physical health, including respiratory health. So issues such as mold, damp, energy inefficiency, insulation inefficiency, etc. That's all contributing to the health of our population within Wales. 58% of our population are overweight or obese, and the cost of that to the health economy is in the region of £316 million a year. We also have 1 in 5 adults within our population that smoke, and that contributes to about 18% of deaths within Wales. And again, a cost to the Welsh economy of around £386 million. Substance misuse is a big problem. Alcohol and Class A drug misuse in Wales is estimated to cost around £2 billion. And then we've also got significant health inequalities across the country between where least deprived areas and we're most deprived. The gap for a man is around 9 years longer if you're in the least deprived area as opposed to the most deprived, and the healthy age gap then is about 19 years as well. So, you know, there's big significant inequalities across the country, and the situation's much the same for females as well. So we're a very proud nation, but we do have some significant challenges.
Get ready to supercharge your live streaming experience with Restream Studio. Absolutely everything you need to run a successful live broadcast right from your browser. Restream Studio.
Thank you. Yeah, so we've got some significant challenges, and I wanted to focus a little bit on what my organisation does in respect of countering some of those challenges and addressing them. So Digital Health and Care Wales, we were established in 2021, and we've got an overarching vision to promote and provide effective digital platforms, services and systems to support health and care across Wales. We employ around 900 members of staff, around about that figure, and we work as a collaborative partner with organisations and health providers across the health ecosystem. So the GP practices, the health boards, the 3 health trusts, and obviously we're colleagues in Welsh Government as well as a devolved nation. We've got an ambitious agenda around integration, interoperability and innovation. And as part of that, we include the expansion of the digital patient record, the creation of a national data resource, delivery of high quality digital services, including cybersecurity, information governance. And I know my colleague Darren was speaking about that earlier today, and digital infrastructure as well. And we also want to enable big data analysis for better outcomes. Integral to all of those areas is the third point on the slide then around common standards, and we've heard that a lot throughout the course of today so far, but in respect of common messaging standards and also the data standards, that's really integral in terms of what we're talking about when we're talking about data quality, and the dependencies on that can't be misunderstood. Security is also really important. As a trusted partner, we need to have the confidence of our citizens and of the health providers that we work with, that we're going to be a trusted partner, and that we use, collect and store data in a responsible way, and that we've got their confidence to take forward that ambitious agenda. We also invest heavily in our digital workforce, and the digital skills agenda is enormous, and we work with academic partners and industry partners as well to bring that digital skill mix within our organisation, but also appreciating where we can rely on expertise of others to increase that capacity and capability to deliver effective digital transformation. I wanted to speak very briefly about my role in the information services agenda in particular, and I know a lot of you, particularly in a health data forum, you'll be quite familiar with the concept of this slide, because it's something that I regularly try and promote as part of the team that I'm responsible for. So there's about 70 plus information professionals within my department, within my team, and they've got specialist data science skills. They're responsible for the acquisition, process and transformation of data that we hold in our national data warehouse within Wales. And as you can imagine, that environment's quite unique because that data doesn't exist in the real world. So what we're doing in terms of bringing that really rich data resource together in the national data warehouse, it's very impressive, and it's such a good asset to the health ecosystem within Wales. It includes around 30 years worth of health data, including 27 million inpatient episodes and 50 million outpatient episodes. And as you can imagine, again, the frequency, size, structure of those data sets massively vary. So essentially what I'm trying to illustrate is that the hard yards and the hard work often happens beneath the surface. It's not the it's not the area where we get all the accolade in terms of the data products that we're providing, where there's a lot of kudos and there's a lot of recognition for some of those dashboards and reports and, the exciting and the sexy data products that we produce. But the stuff that happens under the surface is actually where a lot of the effort is directed. And if I'm being very honest, as some of my team would say, an inordinate amount of efforts directed at the activities underneath. But with that, and I've mentioned previously around the national data resource, we are moving towards a system and a programme whereby we can do a lot of that in a much more sophisticated way. So we're not relying on the legacy systems and the legacy processes that we've had in place. And we do have some technical debt. It's not all rosy. And unfortunately, things do take time to rectify. But through that bold, ambitious programme that we are taking forward within DHCW, the future is looking really promising in respect of what we can do to provide insightful, meaningful data back to the health ecosystem. I haven't got time to show the video, unfortunately, but I understand that the slides will be shared after the session. So I wanted to briefly mention the jewel in the crown, if you like, of some of the work within the information area, and particularly that we take forward on behalf of Wales. So we are part of the Welsh Value and Health programme. And we've got a series of condition-specific dashboards that we publish and we make available back to the system. And they cover, I think we've got about 15 dashboards available now across different conditions such as epilepsy, lymphedema, myeloma, hip, knee, arthroplasty. I can't think off the top of my head, but there's a lot. And what I've done is I've included a link there. So you're very welcome to go and have a peruse at the website. And if there's anything in particular that you wanted to have a look at, I even have a demo. I'm around for the next 2 days, so come and grab me and I can pull you to one side and perhaps show you some of the dashboards. But essentially, we're approach in respect to the Value and Health programme, and again in respect of data quality, it's really recognising and realising the benefit of bringing that rich data and bringing it together in a meaningful way, and actually being a lot more outcomes focused. So we are bringing in PROMS data as well, so patient recorded outcome measures, that's coming into those dashboards and data sets, so we can really start to have meaningful, insightful conversations with clinicians about proper transformation and what the impact is importantly on the citizens within Wales. we also presented those dashboards globally. So we were at ICHOM a couple of weeks ago in Boston, Massachusetts, and we'll be presenting them at ISPO. And we've got a few other areas where we've got some international interest in the work that we're doing in Wales. So as I say, if anybody wants to come and talk to me about that, wants to have a little look, do have a little dig around, but come and speak to me if you want a little demo. I'm happy to do that. And I'll leave it there. So thank you, Diolch. Happy to take any questions.
Do we have any questions for Rachael? From the remote audience? Or
I will check. We have participants from Brazil, but not,
Okay.
yes, but no questions. Oh, it's our guest speaker from Brazil is already online.
Okay. Okay.
No questions.
I have one very short question. So you were mentioning that the reality is kind of spread, let's say, and different between the different literacy and different even financial conditions and so on. So what would you identify as the biggest challenge, let's say, for that change that you want to promote? Is it the literacy not only of the healthcare professionals but also of the population, or is it a matter of financial means to make that change that you want to promote?
I think digital inclusion is an important aspect, actually, and it's something that particularly my organisation's been thinking about a lot in terms of the digital support and infrastructure that we're providing. I think digital inclusion across the ecosystem is really important, both in terms of the citizens, but also the digital staff who are going to be using some of the systems and products that we're providing. We need to ensure that we do equip people with the skills to really utilize those apps and those data products in the best way, so that they can lead to transformative change. So yeah, I would probably fly the flag for digital inclusion.
Yeah, I would say that to utilize and also to take benefit out of them.
Yeah.
Thank you so much, Rachael.
Thank you.
I will then, if nobody wants to make any other question or comment, I will move on to the next speaker, DriesHens from Lynxcare. So he's a medical doctor from education and co-founder and chief business and medical officer from Lynxcare. So the floor is yours. Thank you.
All right. Yeah, first of all, thanks for having us as well. When I first saw the program, yeah, I was quite astonished, because I think seeing it from practice, because we are an IT company, medical IT company, we see a lot of future challenges in terms of health data quality. So I think it's really relevant to see so many different visions about how health data quality is being handled and is trying to be unburdened. So my name is DriesHens, medical doctor, co-founder of Lynxcare. What I want to do with this session today is explain a little bit more from a pragmatic approach how we handle data quality. The reason why we have experience in this with our company is because we are actually a medical data management and processing platform, enabling hospitals to really build clinical data warehouses. So as you all know, the more granular we can generate the clinical data warehouse in standards like OMOP CDM, the better it will be for secondary, primary use cases in Europe for research. An important thing for you to understand a little bit in what we do is it's a publication that we use quite often. Structured data is, of course, a very good basis in the EHR, the electronic health record in hospitals. But if you really want to have valid data that can be used by clinicians, being to generate, for example, insights in shared medical decision-making, it's really important to have both unstructured and structured data sources into your data warehouse. Otherwise, the insights that you'll generate won't be the source of truth. And this can, of course, be in the future as well a very big bottleneck. As you as well know that maybe 80% of medical data today is also unstructured. There's a huge opportunity, of course, for companies like ours to help hospitals, help data partners as well to process these vast amounts of data. But if you're a data processor like our company is Lynxcare, so we work with multiple hospitals in a network. Of course, data quality itself is crucial. As we work with multiple hospitals, we go from data ingestion, the data processing itself, so structured, unstructured data, all the way to making sure that the data warehouse itself is being filled into OMOP CDM. So we use international structures and standardizations. It's really important to make sure as a company that you have a certain data quality framework in place. Not a theoretical one, but something that you can really put into practice. And this is for today and for this session as well, something that I want to highlight because there are so many dimensions of quality, especially in healthcare data, that it's often difficult as well for commercial companies like ours to make a direct line and to, for example, implement theoretical frameworks really to practice. I'm not going to go over all the different variables here. Because I think that a lot of our previous moderators as well talked about this, but I want to give you a little bit or understanding about our approach to data quality when going from source records to a data warehouse. Maybe start with the first quote, but a quote that I think is maybe a little bit too direct, but it shows as well the importance. If you really want to increase health data quality, you have to make sure that you look at data from a given context, being it, for example, lung cancer, heart failure, AFib. And what I want to show with this slide is that data is like garbage, and you better know what you're going to do before you process it. It's the same with healthcare data. So if you start building a data warehouse, being it an international organization or being it a hospital, you have to make sure that you know what you want to do with it. Otherwise, you will never be able to really check the validity of the data, the relevance of the data, the reliability of the data, and so forth and so forth. So you need to scope really a certain project before starting to process or before starting to, for example, collect data like patient-reported outcomes. Where can quality problems arise when building a clinical data warehouse? At our company, we have multiple checks and multiple internal quality control steps because, of course, we train as well algorithms, NLP algorithms that can extract and process unstructured data. But I don't want to go too much into detail. But I see in our company, there are three main phases when going from source records to a data warehouse. It's first of all, the data sources itself. Every hospital has its own information system, has multiple different databases there. So what we do in the beginning is, we look at what's the available structured and unstructured data, how reliable it is, in order to go to data processing, where, of course, for structured data, you have certain ETL mappings that you can apply and codification that you can use to harmonize data in your data warehouse. But for natural language processing, which is the AI technology that can process all the medical records, you have multiple different steps, of course, into quality. Being it, did we, for example, find mistakes in text strings recognition? It's all a little bit technical, but a very good example is if, for example, a physician writes a lot in his record, possible complication of this surgery is XYZ. If you have a data extraction or NLP methodology, you have to know that the metadata out of possible complication is hypothetical. If you don't have that in your data warehouse, then, and you process millions of records for a hospital, it will be quite difficult to have insightful dashboards, for example, as an end product. And it will be quite difficult as well to really make use and valorize your data in the future, because data quality in the full right side, being at the data warehouse, is something that is still really difficult to do in practice. Because from a data warehouse perspective, then you can also have a problem with hierarchy as we standardize to OMOP CDM. And for example, use for conditions, you use SNOMED CT. It has a lot of hierarchies, being it diabetes mellitus can have one code, but a lot of children codes under diabetes. And how far do you go in terms of hierarchy? So there are multiple steps in a process of going from raw data or collected data to really actionable data, being it a structured data warehouse, that you need to take into account. And that's why I just want to show you a little bit of the tools in practice that we use today with our partner hospitals. But of course, this is always work in progress. It's dynamic, like the complexity of healthcare data, but also the quality procedures and the tools used will be dynamic, because the more we know, the more, of course, these can be optimized. If we start working with a hospital, the first thing that we do is, of course, we define a certain context, saying we start with lung cancer, we start with heart failure, then we go to AFib, whatever that is possible or relevant for the hospital and our data partners. But then we start with the data access dashboard. So we provide the hospital with insights even before processing into how reliable and how accessible is the data sources that you have in your hospital. And for example, something that of course happens quite a lot is that you see from getting just an easy visualization into the hospital information system, the volumes, that you can directly do some sanity checks. Like we already discussed, the pregnant man, for example, is a problem. You can have negative length of stays. These are, of course, data points that you see that there are a problem, but you can also have a lot of patients into your hospital information system with missing records, missing reports, which from a data warehouse perspective maybe is not a real issue, but you want to know it before processing, that you can really select what are good data subjects, what are good research subjects, because depending on the use case that what you want to do with your data warehouse, these things and these analyses and insights are really relevant. And this is also something that we can directly discuss as a technology company with the BI department, with the IT department of the hospital, to make sure that the data access side, so the data intake side, and garbage in is garbage out is what they say, is really as extensive as possible, where of course the timeliness, etc., is also being evaluated, because you can have a data source that just goes to 2020 and then it stops, and all the other data sources go to 2022. Then you know, for example, that if you want to use that data source for a specific analytic or a specific query, you want to make sure that it's reliable and that you can't use that data point or variable after 2020. Next, once you have access to data and you validate it with the hospital that the access is broad enough to really build up a good granular clinical data warehouse, we start with processing. Processing structured data is, of course, structured ETL mapping, which is technology that I don't have to explain. For the unstructured part, we use our own NLP models, where we do our internal checks in terms of precision, recall, and so forth, because this is something where in this step you want to give the hospital or the data partner or the user of data, being it, for example, researchers, enough confidence to say, okay, the extraction of variable, let's say in this example, acidosis, is at an F1 score above 0.9, which is essentially the score that if somebody did it manually. So that's the comparison that we can do today, because the previous standard of care was manual extraction. So we always compare versus manual extraction to make sure that the AI, which is essentially just copying that human process, is as accurate as a human, which in all transparency also has its errors. You can't have something that works 100%. What we provide to the hospital in this phase is a type of source data analysis dashboard, which is essentially just an easy interface to look at different data points on the left side. So we call it clinical variables, and they can trace back from where we build up the data point, being it how many patients did we find acidosis in unstructured records, how many patients did we find it in structured data, and how many do we end up with as a total. And then, of course, in the next phase, you as a hospital or researcher, you want to know how did we build up acidosis? What are all the children behind acidosis that is being used to build up this data model? And then you come a little bit in the further phase, which we call a type of data validation dashboard, where not only we from Lynxcare as a data processor for the hospital, but also the hospitals themselves have access to. So there's a full transparency in how qualitative the data warehouse is being built up. And of course, this will create sometimes discussions between the hospital and the IT provider, but it's by these discussions as well that we can learn as a company to optimize all those things. Because as we, for example, work in a network of multiple hospitals and they all have different EHR systems, by getting this feedback on the algorithm and the qualitative approach really from the field, being people in the hospital working with the data is quite crucial if you want to optimize healthcare data. So I just want to highlight that it's not only a theoretical discussion and framework, it's really from practice that you will learn. And it's also from practice that all these things become more reliable, become better, become higher quality, and so forth. What I just want to end with, and I think is really important because we joined just the session, this at noon as well from the EIDS and European regulations in terms of liability. What's really important is if you run an algorithm, for example, in a hospital, in this case, it's for data curation, data processing, that there's full traceback. It's not a black box, it's full traceback. So we provide as well hospitals that want to use, let's say the data point, in this case, respiratoire acidosis, and they want to use a variable for a dashboard or for a real-world evidence report or for multi-center research, that they can always go back to the original source of extraction, which is crucial because then you can really build up a very strong and solid data models in the future. Another thing just to see as well, maybe from the previous slides, if I can go back, voila, is what's important is not only to give a very useful interface to hospitals or people that want to use within hospitals the database, the interface itself, and try to make it as easy as possible is also a challenge, because you will have physicians that need to do some data validation. And as you know, physicians, I'm a physician myself, we are not really trained working with databases and so forth. We are as well not used to doing a lot of data quality control. But I think what is maybe an important one to highlight maybe today as well for discussion is hospitals are more and more investing in data scientists that can work with data, optimize quality and so forth. But there's still a lot to do in the data validity of a database, for example. And there you need the combination between BI experts, but also clinical experts, because physicians know, for example, that 30% of diabetes in a heart failure population is not correct. And even you can do all the checks you can do as a technology company and so forth. And having feedback from the clinical field is crucial in optimizing healthcare outcomes, healthcare data quality. But there as well, there needs to be a time investment from that end. So the more and more value cases that can be built onto this data warehouse, enabling physicians and practitioners to really optimize healthcare using data, the better as well the healthcare data quality will be in the future. So yeah, this was just the small step from going to raw data to a data warehouse that can be used for evidence. I thank you all for your time.
Okay, thank you very much. Do we have any questions from the audience to Dries? Or, okay, yeah, please, sure.
Hi, my name is Rachael. I'm from Erasmus Medical Center in Rotterdam. Thanks for your talk. It's very interesting. You mentioned at the beginning that you also have the possibility to converge to the OMA of CDF. And I was wondering how many of your quality checks, thank you. How many of your quality checks, like the pregnant men, are also related to the data quality dashboard that the Odyssey tool have? Is it
Yeah.
one-on-one, or did you make something new, or?
Yeah, so we use as well the DQF, so the data quality dashboard of OMOP, which is already great. But for the use cases that we want to do, and is really going into high quality data, we just developed our own interface on the OMOP CDM, because internally we use the same interface for development, algorithmic models, etc. But we use as well the standard data quality framework of OTSI, and OMOP. Yeah.
Okay, cool. I have some more questions, but I'll tag you later.
Yeah, perfect. Yeah.
Any other questions? From the remote audience, Paul, do we have anything?
No questions from the others?
Okay, so thank you. So I think that we will move for the remote participant.
Oh.
Do we have to do something there, Paul? Do you know?
No, I think it's already in the line.
Okay.
Yes. Professor Sergio Roll, are you on the line with us?
Yes, yeah, I will share my presentation.
Welcome to Porto, virtually from Brazil.
Thank you so much. Can you see well my presentation?
Yes, it's perfect.
Oh, all right. So let's.
Sergio, the floor is yours. Thank you.
Thank you.
So thank you very much for the organizing committee and Paulo for the invitation. My name and name of the Brazilian Society of Minimally Invasive and Robotic Surgery. The previous lecture are going to help me and make you understand how is a wonderful time to be a surgeon nowadays. Those are my disclosure. Nothing are going to interfere in my presentation. So AI is getting progressively sophisticated at doing what humans do, but more efficient, more quickly, and lower cost. The both for AI and robotics are very, very in our everyday life. Everything we do, it's connecting to the robots. So they are part of our healthcare and ecosystems nowadays. Looking at this article about anastomosis, robotic laparoscopic gastrointestinal surgery, shows how the autonomous robotic surgery has the potential to provide efficacy, safety, and consistency independent of the individual surgeon's skill or experience. They mimetize what we do during a surgery after years and years of training. More than 5,000 surgical robots were used in more than 1 million procedures worldwide in 2012. These procedures extend to all areas: gynecology, gastroenterology, abdominal wall. Robotic surgery is no longer seen as a technology of the future. It's a present technology. Here you can see the review from 2022, how many articles are published in our medical literature. So this was my journey in the surgical fields. I always have loved a good challenge, so I started doing open surgery in 1982, changed to laparoscopic in 90. In 2007, I started to perform endoluminal surgery, anti-reflux procedures, and take the gallbladder to the stomach. And then in 2015, I start with the robot, and let's see what I'm going to do nowadays. What I'm going to present you that I want to do in the next years. So it's a surgeon's duty to learn and safely apply new technology without losing information and skill gleaned from previous training. Keep in mind the importance of stable and proven practice. So I think the surgeon nowadays and in the future, they should know to do open, laparoscopic, and robotic surgery. And we have the digital health and the intelligent artificial tools to help us to better do what we know how to do. So how AI-assisted surgery is improving surgical outcomes? So the advanced analytic and machine learning technique are being used to help to uncover critical insights and best practice, help surgeons to determine what is happening during a complex cases, and provide us real time about the critical moments at the procedure that they learn, the machine learn with previous surgery. To reduce variation and its attending efficiency and poor outcomes. And it's currently being used. We are using this they provide us analysis of our technical skills, a web-based surgical risk and quality management tools that design to eliminate the black box of the surgical visibility. This is using in our practice nowadays. Why are the AI applications? So minimize the risk of surgical complications, understand drives for successful surgeries, predict the severity and type of clinical condition of the patients, predict the likely outcome for surgery, and the better is improve patients' quality of life. This is our goal. Patients' quality of life. Implication for us, for surgeons, increase preoperative choices to determine surgery technique. Preoperative risk rates help us to determine which way we are going to choose. Argument decision-making during the surgery based on real-time analysis and real-time predicting and avoid advanced events. This makes us to be more efficient. Look, this article is not new, from 2003. It's an image-based system which tracks the surgeon facial motions. I use in 2000, I control the laparoscope with a voice control, and this article shows a machine interface for controlling the position of a laparoscope, and prove that it's much better than a voice control, even in a stress moment of the surgery. It's easy to use, rapid reaction, natural communication, and precise during the surgery. With a combination of real-time data insights and integrated software capability, we can manage digital image, make database decisions, and improve outcomes, increasing efficiency in operating room. So real-time communication is the moment for the surgeon and AI robotic surgery. We store individual anatomic data. This helps us to reveal the anatomic of the patient, the anatomy of the patient, and predetermine what type of surgery you are going to do, decreasing the risk and fails during the surgery. Every day, we relay on information from X-ray, CT scan, relay CT scan and MRI, and to determine the surgical requirements and the procedures that we employ to achieve the safest and the best outcomes for the patients. With augmented reality, those records easily appear right in front of us, of the surgeon's eyes, without taking our hands from the surgical field. And this helps us to decide the best approach, the best surgery we can do to our patients. It's amazing how this argument reality help us to decide what to do during our case without asking the nurse to show the X-ray or the MRI. Mixed reality, it's another tool, is a step beyond argument reality in which additional information is added to that which a user perceives. So in MR, the physical and virtual worlds, they are together, they interact, and users can interact with them as well, change position and preventing wrong movements during the surgery, and determine the anatomy structures, avoiding injury in another elements like nerves, like veins. So what will be the next step? Information and energy is the next step. It's amazing. This article from 2015 shows single instruments performing both diagnostic and therapy, real-time, point of care, handheld, portable, and low power. Could be autonomous and home-based consumer product. And these are going to show you will be the next steps. So these instruments can automatically display the tissue damage, may decrease surgical complications. They feel the tissue, they understand the tissue, and they do the job that the surgeon used to do in a better way. So next step is telemedicine and remote healthcare. Do your surgery at your home. It's an OR without surgeons, just controlling with telemedicine in different country, in different places. And this is happening with the 5G and 6G. This augmented reality and virtual reality surgery interact between patients and doctor could help a lot of patients around the world, such in places that there are no those type of surgeon or some specialty. So it will be very important. The future direction of surgery is a non-invasive surgery and is direct connected to energy. We will still do open endoluminal, minimally invasive or robotic surgery, but in each of niche of those type of surgery will continue to change in the proportion that new devices are going to be shown to the surgeons. So this is what I want to show you. Is it's very innovate area. It's a challenge to understand and to use those tools, but at the end will help our patients before the surgery, during the surgery, and after the surgery. Thank you very much.
Thank you, Sergio. I must confess that I am very much impressed with the things that you are showing us. But of course, I will let the audience make some questions or comments in case you have some. Yes, we have a question from the audience. Do you have your microphone with you? No. Do you have a microphone with you? No. Okay.
The microphone is in a way.
Yeah, because for the remote, it's better.
For Zoom,
have,
yes.
Yeah. Yeah. Okay. It's not working?
It will be working in a few minutes. Just be patient. Okay.
Hello.
Yeah,
I will keep the microphone here. Yeah.
Thank you very much to everyone in the panel. I'd just like to address a question to Sergio. I'm a pelvic cancer surgeon. If it all goes wrong, you have to get a scalpel out and go in, and we understand that. The difficulty that we have is this dependency on connectivity. You mentioned about 5G and 6G, and I think what your excellent presentation does is expose the dependency on the hardware to allow people with excellent skills to demonstrate those skills. I'm interested to know how you feel about the remote element. You'll be operating on a console in theatre, and the patient is within meters of you. How are you going to feel when you're hundreds of miles away and things go wrong?
It's a very good question. I think it's difficult, but it's the same as we are doing the robot nowadays. When my patient came to my office and say, "Oh, we are doing iron repair with the robot, so it's not you, it's the robot." And I say, "No, the robot doesn't work alone. I have to be there." But I sit at the console, and I have one surgeon with the same skill that I have bedside of the patients. And I think in the future, if we can perform remote surgery, should be a surgeon with a lot of skill in the pathology that could convert to open surgery or to laparoscopic surgery with the same ability that I could perform. So I think it's a tool. It's a tool to help surgeons. If you imagine, I finished my surgical training in 1984, and I start laparoscopy in July 1990. Was so difficult to understand how achieve to take a gallbladder without a big incision, and this happened. And then 2008 in Brazil arrived the robot, and I said, "This is not a good idea. I think I still need to feel the sensation, to feel the grasper at the bone or at the liver." The robot is so intense. The 3D view is so perfect that when I teach my residents, I say, can you feel the bone? So the image is so perfect that you without the tactic sensation, I think that I am feeling the bone. So this will happen. If we believe or not, will happen. But I agree with you. Without a surgeon at this OR at home or I don't know where, will be impossible. Should be somebody with the patient.
Thank you, Sergio. Do we have any other? Okay, we have two more questions. Then we have to move on, but I will allow the two. Okay.
Okay, thank you for your visionary talk. And I was impressed, especially with your slide where you say, in fact, that future of medicine is information and energy. What does it mean for the education of young doctors, young surgeons, and what can hospitals do with the young surgeons to prepare them for that? Because they are not trained like that in the academia nowadays, let's say average, maybe in your university different, but what does it mean for the youngsters who like to go in your pathway?
Look, this is my concern too. I work in a public hospital here in Brazil. Brazil, it's a poor country. We still do open surgery sometimes for gallbladder, but we have laparoscopy in our hospital. I take my residents to my private hospital to see the robotic surgery, to try to expose them what they could do in other environments. So as proctors and professors, we have to expose them to everything, to new tools, because again, when I was younger and student, everything was about open surgery, big incisions, big surgeons. Now it's about small incisions, big surgeons. And I am in 40 years I finished my medical faculty, changed so much, and now is more rapid. Everything it's happened so fast that I think at the beginning we have to expose them. I think in the future, I never thought when I started university in 2013 in this university that we could perform a laparoscopic pancreatic cancer. And after 5 years, we receive a donation, a laparoscopic, three equipments, and now we are doing everything with the laparoscope. So everything is growing. We have to believe that the future and the present and the future will be so different, and they will be able to adapt themselves to those innovations.
Thank you.
Thank you. So probably we will move on to the next speaker. I'm sorry, and then if we have the time, we will go back to the question. Okay, Sergio, if you can stay online, it will be great. If we have the time. Okay, perfect. So we will move on to the next presentation from Ravi Shankar from the World Health Organization.
Thank you. That was a great presentation, right? Now we should match up at least close to that. Huh? It's going to be a big challenge. But of course, space is the final frontier, right? Like Star Trek, right? Exactly. So we're just going to talk about the new frontiers of use of GIS in public health. I'm going to just give 2 examples. The first one is counting deaths using high-resolution satellite imagery. I let you to see this. What do you judge? So looks like somebody's walking near a burial plot, and in the bottom there are imageries with different time periods, right? One is before, might be the COVID, and during the COVID sort of thing. Huh? And you can see that the space is empty and the other space is filled. I think that's the message. So there's a lot of potentials and possibilities in this area. Immediately, I also start thinking people have multiple questions. Oh, how is it possible? What in case somebody cremates a body? What in case if there is a family burial? What in case there's a lot of unorganized way of putting the burial plots, right? So there are a lot of limitations and challenges in this. I'll start with that. And also, not much studies have been done. The first study was done by London School of Tropical Medicine. They did a good study with our WHO regional colleagues for MN. So there was one study which is already published. So then we started looking into this more closely. This one, I think, is more complicated, right? Not at 4:30 p.m. This is not the right one. But quickly on the right-hand side, you can see it means there's imagery taken over a period of time or a location. But on the right-hand side, if somebody asks a question, when we were during the pandemic, one of our colleagues, Doris Maffard, she was asking, she works for CRVS and mortality statistics and things like that. She asked, okay, can we use this technology to count the burial plots? So that's when we started thinking about it and we started getting into this workflow. This is not for advanced countries, right? It's for countries where there's more other challenges of counting the deaths quickly. Even after a year, you don't get the numbers. So can this be a possibility in those sort of scenarios is what we are talking about. Just to even have a list of burial plots within the country could even be a challenge, right? If it's a multicultural thing with different practices and cultural things. So even that was a challenge for us when we wanted to do a small pilot study. So that's the first part of the flow chart. Then you need to divide the country into various smaller grids, and you need to narrow down to your location of where the symmetries are. Then you need to actually get a high resolution imagery. What are we talking about? The other day I was talking to my son. He was saying, do you know Elon Musk has a lot of satellites. What are you guys doing? He said, oh, might be. I thought it's 510. Actually, they have company has more than 2,500 satellites up. Huh? So the technology has advanced so ahead of us. So what are we talking about high resolution? It means any object which is less than a meter resolution would be visible. So we are talking about like 35 centimeters or 40 centimeters resolution. It means a table like this or an object like this, when it is outside, it will be identifiable. We had seen like a bunch of giraffes in the satellite imagery. We have identified elephants, even group of people. So it is possible. The technology is really, we are able to see in Google Maps and things like. So that is getting the imagery, processing the imagery, and sort of doing an automated feature extraction. So you should be able to extract from the imagery. Of course, you can use a manual extraction of putting dots over every plot and say, okay, this is what is the number is. And then you need to be able to repeat it regularly, right? Because it can be one time done easily, but how do you keep on repeating it? And there's so many challenges in just doing it. The type of material, it could be granite, it could be wood, it could be soil. There's so much challenges around it. But it's still an upcoming area, but I thought it'll be good to share. We took a symmetry in a country, just as an example, even though there was mentioning that there were very less number of COVID deaths and things. So we just took as an example for our study purpose. So the first imagery we got is from 2016. So at that time we counted, there were around like 300 burial plots, assuming that each plot is one person is buried there because it's not a family burial or so. And then we took another imagery because imagery does not lie, right? You can go back in the past and see we got another imagery in 2016 to after 2018. So we then counted for that. Then we counted for, and then we did for the recent one. I don't want to give any observation on things. You yourself can divide and see by the number of months and see if there is an increase or decrease you can find. So the message here is we can use this technology and explore more to see into this direction. So the second example is we're just publishing a handbook called Microplan Handbook. Not many of you would have heard about this. This is a very specific, which is related to immunization, which also became very popular during COVID time. My Director General, Dr. Tedros, was saying in the media a lot of times, right? When 16 vaccines were going to the Western world, there were like one vaccine went to Africa. But the question in front of us there is, even that one vaccine, where does it reach? Does it reach the affluent people there? Does it reach the main city? Is it also reaching the vulnerable and the last mile? So that is the question we are trying to answer. And this is not a new one. This is well trusted and worked out in the world of polio eradication. If you guys have heard about polio eradication, we are very close to eradicate. There's only 2 countries which has polio now and very small numbers. There'll be a massive victory for the public health. After smallpox, this will be one, if it is eradicated, it's going to be very eradicated soon. I worked 10 years for polio eradication, where we had good amount of research and technology use there. I'm going to talk about that. This context of microplan actually comes from there. And what does it mean? There's a hospital. Somebody has to go to a hospital. A mother has to take the child to the hospital to be vaccinated, right? That's one concept. Or conversely, you are going from the hospital to every household to vaccinate them. There are two possibilities, right? Because if there is an elderly, or there is a kids and other things for polio, we actually go to every door-to-door of every house to vaccinate the children. So two scenarios are here, but the concept is, how do you make sure that everybody is reached? Is there an equitable distribution? That's the question we are asking. I even say this analogy between what is the commonality between a McDonald's and a health facility, right? Both of them are doing some sort of service delivery, but in most of the times, McDonald's does not fail, right? Whereas we see in difficult countries, people pass by a health facility, they don't even notice it. They don't even know, because this is why I say, is a facility by chance or by choice? Because there had been a government property long years ago and it's just still there, but nobody would like to access there for various reasons. So this sort of question to ask, actually technology can help us. So what are we trying to do in the digitization or the digital component? This is what we're getting, geo-enablement of microplan. So it means, this is a picture which actually I took when I was in Somalia working for polio eradication, where we used to call our vaccinators and tell them, can you mark your area for the day? Which area you're going to cover, how many houses you're going to cover? And then we used to mark that, and then we'll ask the next vaccinator to mark the area. Then we'll see if there is overlaps or gaps. Because buildings come up, peripheral area comes up, urban sprawl, everything, new settlements always are coming, right? Then we were checking if they are able to match or not. This is how we started like long years ago. Then we are moving into this. So to do a digital microplan, you need only 5 things. Satellite imagery you need to know where people are living. If they don't exist in the map, it means it's very difficult for us to reach them, right? So we need to know where they are living. We need to know the roads and accessibility for that. We need to know the catchment boundaries. So these are the things if you have all these things, imagine you have all these things in the world, then I think we could see if there is an equitable distribution. The other question, I think a lot of time it comes is universal health coverage. What is actually meant by universal health coverage? To see if everybody is able to access to the health facility, right? How do we even actually measure that if you do not know where your health facilities are? If you don't know exactly where your health facility is. The common myth is everybody thinks that everybody knows everything. So to address these things, we started interfering in, or putting our energy on each of the components. First is on the satellite imagery. We had some access to good imagery, thanks to CDC and the federal government. So we were able to have high resolution, good imagery. Then the next is, how do you do your feature extraction? So we started investing on this area. It's called a RAM project. It is there in online, you can go and see. To digitize, convert a raster image, a picture image into a usable vector data. That's what we are trying to do here. But to do that, you need to have training samples, you need to have high resolution imagery, and you need to have a software to do it. So this is the area we are working to make it open. A lot of entities are done this, right? Facebook, Google, Microsoft, many people are actually doing in this. So the next thing is we were started focusing on the health facility. Actually, where are our health facilities? And are these health facilities have a unique code? In this project of geolocated health facility data initiative, we are just asking for 3 parameters: the name of the facility, the type of the facility, and the location of facility, with a unique code made public in the ministry's website. Looks very simple, but for 194 countries, will it be possible to make this public so that everybody could use one source of truth? Might be it might exist in some place, or I always say with the cube example of XYZ, the x-axis is how open is the data set. Is it open with the payment? Is it open with the email, or it's open for a limited people, or it's totally open? That's the x-axis. Y-axis is how complete, how accurate, and how timely is that data set. And the z-axis is, even though if it is made public in ministry's website and it is available, who is actually using it? So if you put, like we started the project now with 50 countries, mainly in Asia, Africa, to put a cube, and we are trying to place every country in this location. Might be in x-axis, they might be in 50% or 100%. Y-axis, they might be in 10%, 50%, 30%, we do not know. But this is what we are doing, a landscape analysis, and we are engaging with the ministries through a very structured way of 7 pathways, from advocacy to data interoperability, to financial sustainability, to innovation and technology. We are addressing this project. This is a very big flagship project by our GIS center. So the next one is to do the drive time analysis. You need to know, right? 15 minutes reach, 30 minutes reach, 45 minutes reach. So we are, this is a tool which was built by WHO long years ago, 2002. It started developing, and now we are going to the next generation. It's actually a tool which you need to install in your machine and do this. Now we are totally going to online, like Google Maps. Actually, for this, we are thinking if Google Maps you put from point A to point B, you're able to get your navigation route, right? Similar to that, I have my health facilities for my country. Can I just drag and put it? Will it give me drive time analysis for each of the health facility to say within 15 minutes of these health facilities, how many population are covered? 30 minutes, how many? It's a simple network analysis or cost benefit analysis, which we do in GIS, right? This is the another area we are doing a totally online version of this. Finally, I wanted to come to this last slide. Doing this, what is that ground reality actually looks like? This is an image from Nigeria. These small dots are the settlements. And these areas are the areas where a vaccinator has to cover in day 1, day 2, day 3. So to do this, we have to do all these processes, but it does not end here. We even did a little more step in polio. What actually we did is we gave mobile phones to each of the vaccinators who are going to vaccinate the children. We are tracking them from morning to evening, every day of the campaign. We call it as a polio campaign. Like an election campaign, we have a polio campaign. It goes for 5 days. Within 5 days, in a day, they can cover like 100 households or so. In 5 days, they have to cover 500, 600 households. There's thousands of people goes. On a given day, we gave like 20, 25,000 phones. And they used to have it there. They cannot do anything with that. If they go very fast, it will not count. If they are in a place, it will still put in them. What we did is yes, almost done. This is the last slide, I promise. So we had this base image now to compare. So this is the denominator. Then we allowed them to go and we are tracking them on a daily basis. So if they don't cross this, each of the path, each of the settlement, each of the households, it means then we get an analysis of how much percentage actually they covered. So if the analysis say at the end of the day, they covered only 70%, we need to send actually a mop-up team. It improved the quality of the data so much. People were accountable. Even some of them were let go from the project because some of the people were sitting in a tree half a day and just coming back and saying they're vaccinated. Then the accountability framework went little more to their supervisors to see if the supervisors also are going and checking. So every level where started getting this accountability. So what it made difference is it created a transparency, it created accountability, and it saved the program so much in totality. I stop here. Thank you.
Thank you, Ravi. I don't know if we have any questions for Ravi
Not from the Zoom, no.
from the audience. Okay. If not, maybe I will use the time. I don't know if we still have the same participant that wanted to make an additional question to Sergio Roll. So maybe we can use the time to, because we have now 3 minutes up to our session end.
I'm very appreciative that the audience is self-organizing to distribute the microphone. A round of applause. Thank you so much.
Okay, so Sergio, I think that you are still with us. So maybe, yeah, if we can hear the question. No.
Mike.
Problem with microphone
Amazing audience. We have a self-organized audience that takes care of the.
and the technical support one also.
Yeah. I think the technical room, we need the yes. Precisamos de áudio aqui no microfone.
No, if not, may I suggest that you
Miguel,
just,
precisamos de áudio aqui no
if
microfone.
you can come here, we can use one of ours. I mean, probably it's faster than
You,
just.
you can go to the podium if you like.
No, thank you very much. I think it's enough here.
Okay,
Hello, Sergio, can you hear me?
can you hear? Yeah.
Yes. Olá.
Yes, I can.
Não, sou portuguesa. So I'm a Portuguese citizen. I would like to ask you something. In a world that is supposed to, like Ravi said, a full universal coverage for health. It's working. Hello again. So in a world that, like Ravi said to us and remembered us, that it's supposed to all of us have a universal health coverage, where do you see those kind of highly specific technologies like you presented us in a short and long term? How can robotics be adequate and universal usage for every person in the world?
Very good. Very good questions. I'm part of one organization that's called Hernia Help. It's an American organization, not profit, and we perform mission in Africa, South America, and United States. We do hernia surgery in adults and children that cannot receive surgical treatment. And we have to go in those places to perform those surgeries. And we add something different, that we train surgeons, local surgeons, to continue our mission when we come back to our countries. I think the AI and robotic surgery are going to help us, first of all, to teach them how to perform the surgery without being there. This is something that it's possible with avatar and artificial intelligence. Other thing that happened when the United States invade Iraq, when they come back to, when they return and they left the country, there were a lot of hospitals without any surgeon special with any specialty. They are general surgeons. So when they have a difficult case or a gunshot in the brain or in the hand, and they don't have the specialty, they had a robot there. Just was a image robot that focused on the damage, and the surgeon in the United States helped the surgeon there in this OR in Iraq, how they help them to perform the surgery without any help with the robot, just the image. So can you imagine if we have an avatar, as for example, my avatar in a place in Manaus, here in Brazil, that it's a 6-hour flight, helping a surgeon with my avatar performing a hernia surgery. I'm not talking about now complex cases, but more simple cases. This is helping now in Brazil. So I think in remote places that we don't have any type of doctors or any type of special surgeons, we can use now and in the future. Countries like Africa and Brazil will have a lot of benefits of this technology.
Okay, thank you.
Thank
Sergio.
you.
Thank you.
Thank you for
Thank
the
you.
opportunity.
We have already exhausted our time for today's session, and we need really to close because I think that the next plenary session is waiting to start, right? So we really need to close. Thank you for all the speakers. I mean, the topic is so broad and brought together so many different points of view and perspectives that I think that we could stay here for many hours discussing the different different perspectives and challenges in so many different settings. Once again, thank you very much, and enjoy the rest of the day. Thank you, Sergio.
Thank you. Obrigado.
Thank you so much, Maria Marques, for this roundtable moderation, presentation moderation. And now we have the roundtable coming in, and the next moderator already in the room. Again, Vanessa Candeias is joining us. It's been a long day for you, Vanessa, but it's really great to have this final across the world plenary session now. We have a 10 minutes buffer, so you can grab a coffee if you like from the bar, or if you have any tickets left. And oh, William. Guest speakers in the room, please join the table. Jocelyn, please join the table. And we are still live. Broadcast, but maybe we can close this broadcast now.
Yes.
And we'll be back in a few minutes for the cross-world plenary.